Assalamu alaikum, Sisat Sawakum. Good morning. My name is Ibrahim Sbeih and we are transmitting live from Farah Medical Campus here in Amman, Jordan. And the backdrop is a slide showing Jarash, which is a Roman city. It is the kind of city that you would not see outside Rome. And the topic for today is the orbital intraconal tumor, clinical, radiological, operative, pathological correlation. So let's have an idea about the orbit. I have to warn you, this lecture is very condensed, so I have to go very quickly. So this is the orbit. And in the orbit we have the rule of 7. 7 bones, 7 arteries, 7 veins, 7 nerves, and so on. The rule of 7. Here is the orbit. It's a close look. This is a real skull, and you can see this is the frontal bone, and this is the greater wing of a sphenoid. This is the zygoma part, the zygomatic process. This is maxilla. This is lacrimal bone, ethmoid bone, and deep inside is a piece, very little piece of mandible. So here we are. So more 7 bones constituting the roof of the orbit, the floor of the orbit, the medial wall of the orbit, and so on. And we are looking at the left orbit. Why I'm concentrating on the left orbit? Because the case that we have has a left-sided orbital tumor, so I would concentrate on the anatomy and the left orbit. Here you can see the severe orbital fissure. You cannot see the optic canal here, so you have to rotate the skulls that you can see the optic canal and the severe orbital fissure. Optic canal, severe orbital fissure. And here is the inferior orbital fissure. So if you are looking from above at the left orbit, this is the greater wing of a sphenoid, and this is the inferior orbital fissure. And this is the ethmoid. Of course, this is the maxilla. If you look from above, you will see the sphenoid bone and the 2 optic canals. Optic canal is a canal inside the lesser wing of a sphenoid. Sphenoid bone is made of body, a greater wing, and lesser wing. And the optic canal is a canal inside the lesser wing of a sphenoid. So you will see the optic nerves here, the carotids lateral to it. We are sitting on top of the sella turcica, olfactory tracts, optic nerves, chiasm, carotids. So this is the medial wall of the orbit here. So what is intraconal? What is the terminology? What that means? If you look at the skull again, this is the right orbit, this is the left orbit. The medial wall of the orbit is straight, the lateral wall is going outside, so you get the kind of a cone picture. And from here, the annulus of Zen, we have the muscles. So anything inside the muscle is called intraconal. So here is the optic nerve and the muscles surrounding it at the apex of the orbit. So intraconal means within the cone of the muscles, just like that. So annulus of Zen, sending its muscles, lateral rectus, superior rectus, medial rectus, inferior rectus. If you are inside this cone of muscle, then this is called intraconal. While anything here between the muscle and the bone is extraconal. So again, looking at the left orbit from above, this is optic nerve. You can see that the medial wall is straight, the lateral wall is going outside like a cone. But we are not looking at the bone, we are looking at the muscles. This is medial rectus, lateral rectus. Anything inside, which is the black asterisk, is intraconal. Anything outside, between the muscle and the bone, is extraconal. If you look at it from the above, this is the right orbit, this is the lacrimal gland, these are the muscles, so anything inside is called intraconal, the black asterisk, and here is the extraconal. Again, here you can appreciate this on the radiology. This is the optic nerve with the surrounding subarachnoid space and the dura. And that's why the intracranial pressure is transmitted to the eyes. That's why we say the eyes are the windows to the brain, because if you look into the eye, you will see papilledema, which is transmission of the intracranial pressure around the optic nerve. This is the lateral rectus, medial rectus, superior rectus with the levator palpebris superioris and tub, inferior rectus, and so on. So, and again, anything inside is called intraconal, anything outside is called extraconal. Again, here appreciated on radiology, this is the globe, this is left globe, lateral, medial, this is medial rectus, this is lateral rectus, the optic nerve. So intraconal also is divided into medial compartment and the lateral compartment. Medial compartment and lateral compartment. And you have to appreciate that optic nerve like to go medially because it will reach to the optic canal here. If you look laterally, you can appreciate the globe, etc., and the superior rectus, the lateral rectus, superior rectus, and levator palpebris superioris, and it divides into two parts. Part that goes into molar muscle and part that goes into the superior tarsus, and this is the orbital septum that divides this into preseptal and postseptal. So we are talking about intraconal and extraconal. We are speaking about medial compartment and lateral compartment of the orbit. We are speaking about preseptal and postseptal compartments. Quick look in the right eye. Here we have removed the skin and so on, and we are looking at the muscle, orbicularis oculi, which is made of two parts, one around the orbit and one in the tarsus. If you remove that, you look into inside, then you can see levator palpebris superioris. These are the muscles, lateral rectus, medial rectus, superior oblique, this is the superior oblique and superior rectus and the levator palpebris superioris, inferior rectus and oblique muscle. These are all the muscles that you can see with the intorsion and extorsion. If you look at the left eye, the same, this is the nose, this is the left eye, just the same arrangement, and you can see and appreciate the muscles. So if one wants to go into the orbital surgery, one has to master the orbital anatomy. Left orbit, maxilla beneath. We have removed the anterior wall of the maxilla, so we are back into the pterygopalatine fossa. This is a foramen for V1, and this is a foramen for the median canal. All goes into the pterygopalatine fossa. This is the orbit. Again, for a facial-maxillary surgeon, this is very important, as much as it is very important to us neurosurgeons. Here we have the small foramen for the orbitozygomatic and frontozygomatic branches that the anesthetist or the ophthalmologist sometimes anesthetize to do orbital surgery or ophthalmic surgery under local anesthesia. So let's look at the orbit from above. This is anterior fossa, middle fossa, posterior fossa. This is sphenoid bone. And here is the plate from the frontal bone that constitutes the roof of the orbit. If you remove the bone, then you will get into the periorbita, which is a fascia kind surrounding the orbit. This is optic nerve left, optic nerve right. Again, appreciate that the medial wall is straight, lateral wall is going outside like this. If we look at the lateral view, and you remove the bone and so on, then you will come to this area. This is the lateral, or the greater wing of a sphenoid. This is the eye. The lateral wall of the eye is made mainly by the greater wing of a sphenoid. You go deep and remove the bone, you will get into the periorbita. And if you open the periorbita, then you will get into the orbit itself. And the first thing that you will meet laterally is the lateral rectus. So whether you will go above or below depends where is the lesion. Here, you open the window between the superior rectus and the lateral rectus, you will find certain structures. If you go below, you will find different structures. This is the superior ophthalmic vein, this is the inferior ophthalmic vein. Why am I mentioning all this information? Because we are going to see it during the movie. So, we now know what is the orbit, we now know what we mean by intraconal description. So, orbital lesions. My personal experience in this, since '85, since I came back from London, 126 cases, females more, thanks God, after the males. benign tumors more than malignant tumors, and we have other collection of tumors. I did not realize I have such a good number of cases until recently. So how do we think about orbital lesions? You may think about the pathology. You say, are these tumors, or are they inflammation, or are they infection, or are they congenital, or are they vascular? You can think of this pathological classification. You can also think about orbital diseases. What are the orbital diseases that affect the orbit? IOP, idiopathic orbital pseudotumor, thyroid disease, etc. A group of diseases, sarcoidosis, Wagner amyloidosis, IgG4, etc. as disease. If you think about tumors, then you can think about the structures. What are the tumors that arise from the globe? What are the tumors that arise from the optic apparatus? What are the tumors intraconal or extraconal? What are the tumors that come from the surrounding structures? What are the tumors that come from the bone? And what are the tumors that affect multiple compartments? So this is a way of thinking about these orbital tumors. If we think about these tumors, they are rare, 1 in 100,000 persons, and in children, 80% are benign, 20 are malignant. In adults, it's a little bit different. It's almost the same, almost. So what are the lesions or the tumors that can come from the surrounding structures? I mean from extraconal. Extension from meningioma. Look at this. This meningioma started here somewhere, cavernous sinus or petroclival, and it was treated badly, either by doing nothing or by giving radiation like gamma, and look at the end of it. Extension into the orbit. Or again another meningioma extending into the orbit because of bad management. What we tell patients is something bad, that meningiomas are benign tumors and they grow very slowly and you can wait on them. They grow 1 millimeter every month or every year. This is a false statement. Meningiomas are aggressive. سجل لي دكتور ريا. Extension from surrounding structures, pituitary adenoma that went into the orbit, inside the orbit, from pituitary adenoma. Again, pituitary adenoma are not benign. There is something called atypical adenomas and something called aggressive adenomas. You always come at the lymphoma part. Take care, don't fall, please. أنا حطينا هذا الحاجز عشان الدكتور. So this is the patient that there is extension to the orbit, and you can see the presentation of third nerve palsy. Extension from a mucocele or pyocele for that matter. So it starts somewhere in the sinuses and go into the orbit. Like this one, pyocele. So these are tumors or lesions from the surrounding structures. Extension from sinuses. Eosinophilic granuloma, and it's 3 types. If it is focal in the skull, it's called eosinophilic granuloma. If it is multiple in the skull, it's called hand-Christensen disease. Multiple, but in the same organ. If it is multiple but in different organs, systemic, then it is lateral Sbeih syndrome. This is one girl with this isolated lesion in the roof of the orbit. She is from Iraq. You can see the presentation there. And this is the surgery that was followed by radiotherapy, and she recovered completely. This is histology from Dr. Farsakh. Osteoma in the roof of the orbit. Extension from tumors in the sinonasal area, sinonasal, nose and sinuses. Special terminology, sinonasal adenocarcinoma. Look at this extensive tumor. So this is the patient from Sudan, 34-year-old, with this proptosis here. And you may think that this is inoperable. It is operable. That's what we did with my facial-maxillary surgeon, Dr. Sata. We removed the tumor completely. Sinonasal adenocarcinoma again, before surgery and after surgery. Adenoid cystic carcinoma. Squamous cell carcinoma, extensive. Undifferentiated carcinoma. Malignant round cell tumor. This is one of my patients, 28-year-old male patient, and he had this lesion here, turned out to be malignant round cell tumor of his lacrimal gland. And this was reported by Dr. Shabi. Is he around? No, he couldn't make it. That's his malignant round cell tumor. Ewing sarcoma. Orbital sarcoma, esthesioneuroblastoma, which is arising from the olfactory tract, it's a malignant tumor, giant cell tumor. So as a neurosurgeon, you have to be prepared to deal with these cases because they are approaching on your territory. Plasmacytoma, whether single or multiple, chondrosarcoma, rhabdomyosarcoma. This is a story on its own. Rhabdomyosarcoma is a fatal, almost fatal disease. In the past, now there is some success in the management with the chemotherapy. Am I right, Anna?
Oh, yes.
Osteosarcoma, giant cell tumor again. What about lacrimal glands? These are extraconal, outside the cone. So lacrimal glands, like any gland, either they are epithelial, like ductal, like breast carcinoma may be ductal, and again ductal carcinoma or ductal system in the lacrimal gland will give you epithelial tumors. And there are benign tumors and there are malignant tumors. The most malignant is adenoid cystic carcinoma, or it could be non-epithelial. This is an example of lacrimal gland. This is not one of my cases. This is from Anne Osborne. As I promised you, every time I put a case from others, I would mention it. Other than this, it would be my case. So whenever you see an arrow like this, it is not my case. This is from Anne Osborne. The others are mine. This is not mine. Now, these are examples of metastases from anywhere in the body. And look at here, they go into peculiar spaces, peculiar places, these tumors. And they could be lytic or they could be osteoplastic. Lymphoma, and many times we mentioned this is a forgotten disease. People don't think about it. We think in a very monoplanar thinking. We think of, if somebody comes with abdominal pain, we think of appendicitis or ovarian cyst rupture. There are thousands of pathologies there. And if a patient comes with headache, it is hypertension. Wrong. We have to expand our knowledge to face the challenge of dealing with these patients. Osteoblastoma, sinonasal pseudomonas fibroma. This boy had surgery somewhere else, and he was diagnosed as having malignant tumor. So a biopsy was taken, which is wrong, and he was sent for radiotherapy. His father did not want to believe this. He came to us, and we said, no, we can do something. This is him, this is his previous surgery. We went in and we removed the tumor completely, and it is a benign tumor. No radiotherapy, no chemotherapy, just excision. And this is the patient as he grew up. Aneurysmal bone cyst. And I showed you this case, we present it here in this room. Aneurysmal bone cyst, multiple cysts with multiple fluid levels in this young boy from Iraq. Extensive tumor, again, he was told that this is malignant tumor, leave him alone. Leave him to die. Why? Because the surgeons who've seen him, they are mediocre, they cannot do the surgery, so they say something which is totally wrong. So we went in, and it was aneurysmal bone cyst, very benign tumor. Radical excision, and the boy recovered well. Fibrous dysplasia can affect the orbit extensively. This is an Iraqi chap with this fibrous dysplasia. Again, we went in and removed most of the tumor. And if you are left with tiny little pieces, this is self-limiting disease, and it most likely will not grow again. Fungal infection, extension of fungal infection into the orbit. And this is one of my patients, patient from Libya with this extensive fungal infection going into the frontal lobe and the orbit. And again, we treated him. And this is the specimen, the hyphae and the pus. Is Marwan here? No. These are the hyphae of the fungal infection. And this is a very interesting case from West Bank of Jordan, Palestine. And this boy came with this mass. There was nothing in his history. As I went in, there's lots of bone and there is a mass in the orbit. What did I find? That this was a brain tissue going into the orbit. This boy had a fall as a child, as a youngster. He fractured his frontal bone. There was tear from the dura, CSF went in, brain went in, and constituted a mass. So we just pulled it back and repaired it. Leptomeningeal cyst, or disappearing skull syndrome. Another case, again, with this trauma. This is massive mass inside. All this mass was brain tissue going into the orbit. Again, we pulled it out and we repaired it, and the patient as well. Another case of oxoencephalocele, or disappearing skull syndrome. Again, it is presenting as a mass. And this is the post-op, and this is the lady after surgery. Or the lesion can be intraconal. What are these lesions? So we describe the lesions that come from outside. Let's describe the lesions that come from inside inside the cone. You can have retinoblastoma, which is a disease of children, as you know, very malignant. Or it can come from, in the adults, the uveal melanoma, like this one. So uveal melanoma is a disease of adult, retinoblastoma is a disease of children. Diseases that come, we describe the globe lesions. Well, let's describe the optic nerve. We see something called optic sheath meningioma. So it's called the tram line track, like the lines of the tram. Very characteristic. These are very slowly progressive tumor, and most of the time the treatment is conservative. No one nowadays go to excise an optic sheath meningioma because you just can't. It grows into the optic nerve, so leave it alone. Another optic sheath meningioma, which is large, a little bit large. Again, the tram track sign is still there. You might have a large mass like this, which is just complete intraorbital meningioma arising from the dural attachments there.
Does it extend if you leave it, the optic sheath? Would it go?
It may, but it's very, very slowly, very slow growing. The other one is the optic nerve glioma that goes into the cancer, but optic sheath meningioma rarely goes to the cancer. And this is one point of differentiation. Sometimes you have meningiomas in ectopic places, not related to the optic nerve, not related to the dura, it's called ectopic. It was described recently in Journal of Neurosurgery. And I would ask our residents here, do you read any journals in your discipline, whatever your discipline is, ophthalmology, gynecology? Because you must read these journals. You must read 2 or 3 journals at least in your discipline, and you must publish at least a paper every year. So this is a recent publication, ectopic orbital meningioma. Meningioma that extends from the sphenoid, we call it sphenoorbital. Sphenoorbital, like this one, before surgery and after surgery, and this lady from Yemen. Related to meningioma is hemangiopericytoma. It was in the past grouped with meningiomas, now it is different separate entity. It's called hemangiopericytoma. It looks like a meningioma. Third thing that looks like a meningioma is the so-called pachymeningitis hypertrophica, or the so-called IgG4 autoimmune disease, and you will get lumps and masses like this. IgG4. I have cases in the spine, I have cases in the orbit and in the brain. They very much look like a meningioma. Optic nerve glioma, which is different from optic sheath meningioma. Glioma of the optic nerve could be within the orbit, it could be within the canal, it can go outside into the intracranial. It could be bilateral if you are having an F2 and F1 patients, neurofibromatosis type 1, you can get bilateral. Optic nerve gliomas, rare, they can come bilateral in an F1. This is the age, but you can get it even in 80-year-old. Where do they occupy the optic nerve? Either in the orbit, or in the canal, or intracranial, or in the chiasm. In children, it is benign. Astrocytoma type 1 in adults is high degree. So optic nerve glioma in adults is very bad, especially if there is involvement of the chiasm or if there is intracranial extension. They could be large, but still you will get this kind of sign. This is optic nerve glioma. You can see it inside the orbit, in the canal, in the chiasm, and even in the optic radiation. So this is the clue to have this distribution. This is optic nerve glioma. You can have tumors from the nerve sheath like a frontal nerve or whatever nerve in the orbit. Usually we involve V1, and in a neurofibromatosis it could be single or plexiform. It could happen in an F1 and in an F2. Example of these plexiform neurofibroma. This is not my cases, this is published in this paper. Cavernous hemangioma. Cavernous hemangioma is the most common tumor in both children and adults. So if you ask me what is the commonest tumor you have seen, I will tell you primarily cavernous hemangioma. Extension from sphenoorbital meningioma. So this is the cavernoma, which is the optic nerve. It's inside the cone. It is intraconal pathology. Here you are. It could be large in size. 80% of them are intraconal. They may have these skin changes in children. Yes, but sometimes they are associated. This is capillary hemangioma, true, but sometimes they are associated. And they have excellent prognosis because they are well contained, well capsulated. This is a cavernoma of this patient of mine, 39-year-old female. This is the histology, cavernoma. So every case we put has been histologically operated upon and histologically confirmed. Another patient of mine, 40-year-old male patient with this tumor and after surgery, and this 31-year-old female patient with this hemangioma in the apex of the orbit. It was extremely difficult, really, extremely difficult. And this is the follow-up after 4 years with very good results. No proptosis. Another patient of mine with the right orbit cavernoma before surgery, and we used the frontozygomatic approach, superior approach, and this is the post-operative. So because it's extending up, I'd like to come here in the roof of the orbit. In infants, sometimes we call it infantile capillary hemangioma to give it some peculiarity, that it is cavernous hemangioma, but its name is infantile capillary hemangioma. Again, this is not my cases, this is from Osborne and Osborne. Lymphangioma, again, these are not my cases. I have not seen a case of lymphangioma. Lymphatic tumor, dermoid tumors. And this is one of my patients with right-sided dermoid tumor, preoperative and postoperative. Optic nerve sheath meningioma or optic nerve glioma, this is the question. How do we differentiate? That gliomas can extend into the canal, into the chiasm. Meningiomas don't. Gliomas in adults are rapidly growing, meningiomas are not. We have lesions which are not expected, but we stop thinking about them as if they don't exist. They are there. There are patients with sarcoidosis who will come to you with the tumors, major tumors, like this. This kind of patients are treated usually with gamma, which is a crime. Treat sarcoidosis with radiation and you will kill. Why? Because the surgeon cannot operate in this area. You just want to give blindly the radiation. and to hell with the patient, so long that he gets the money. Wagner granuloma, again another forgotten disease. Giant, it is a large giant granuloma, anti-histologically verified. Orbital cellulitis, infection. It's different from idiopathic orbital pseudotumor. Idiopathic orbital pseudotumor. Pseudotumor because the lesion resembles the tumor, but it is an inflammation and not infection. It is inflammation without local or systemic causes. I have seen several of these cases referred to me for surgery. When you dig deep, it's just an inflammation. It's self-limiting disease. It's inflammation and not infection. How can we tell? It looks like a tumor. Look at this. It's a tumor. But look at the age, 30 or 50, and there is inflammation of everything. Scleritis, uveitis, lacrimal adenitis, myositis, perineuritis, everything in the orbit enhances. That's the clue. If everything in the orbit enhances, this is pseudo-tumor lesion. And the treatment is just steroids. Idiopathic, affecting muscles, affecting a gland, affecting the sclera, affecting the nerve, perineuritis, affecting the lacrimal gland. So much so that if you see lacrimal gland affection, then think of pseudotumor. Ethmoiditis. If it is one side, it's called still disease. If it is bilateral, it's called Sjogren syndrome. And this is very known by our rheumatologists. We stop asking the patient, do you have redness of the eye? Redness of the eye, ulcers in the mouth, some lymph nodes. You have to think of some autoimmune disease and the rheumatological diseases. Another case of idiopathic orbital, just like a tumor. Tolosa-Hunt syndrome, optic neuritis associated with others, with scleritis and others. Thyroid Graves' disease with the enlargement of muscles. Again, this is systemic disease. And last, one of the rarest pathologies is to have echinococcus granulosus in the orbit. It can go anywhere. So we have seen the broad spectrum of the pathology in the orbit. Please. Let's give me time to very quickly.
Morning. Just few oncological insights into this huge list of differential diagnoses that you've just witnessed. These are actual cases. This is not a mental exercise of what could this be. These are actual cases that presented, most of them in the same pattern. And it's very important to emphasize a few things. One, you want to make sure this is not infectious. And you've seen few examples of this, and fungal infections can present in this manner. Two, you want to make sure this is not an inflammatory disorder, and you've seen ample examples of this. Most of the other things that list of differential, you've seen the treatment of either observation or surgery as a primary treatment, and nothing else is going to work. I'm going to emphasize a few things that are going to be treated radically differently. Sarcomas in the orbit will be treated radically differently, and sarcoma is not a one diagnosis. There's a very different implications for having a chondrosarcoma in the orbit versus Ewing sarcoma, the latter being susceptible to multi-agent chemotherapy and would respond dramatically to multi-agent chemotherapy. Rhabdomyosarcoma of the orbit is a huge spectrum of disorders with the difference between infantile, pediatric and adult manifestations, and multi-agent chemotherapy, particularly in pediatric rhabdomyosarcoma, is pivotal. Plasmacytoma in that age, which is a plasma cell disorder, in the absence of anything else to make it a multiple myeloma, these three lesions are very susceptible to radiotherapy. And they would not need surgical intervention after you actually know the diagnosis and rule out multiple myeloma, and if it's multiple myeloma, they will need systemic chemotherapy. Histiocytic disorders is a long list of disorders that you have to ascertain. You really want to make sure it's not an inflammatory disorder and or something on the lines of sarcoid. And a common disorder in the orbit is metastases. And the list is lengthy, including breast cancer, and I can't tell you how many breast cancers presented in the orbit with nobody bothering to manage to examine the bed. And last but not least, lymphomas, and it's not one disease, it's at least 95 different disorders, and orbital lymphomas is a lecture in its own. But the lymphomas that have predilection to the orbit would either be marginal zone lymphomas, which are low-grade lymphomas generally that are very slow-growing. Diffuse large B-cell lymphoma, which is much more aggressive and rapidly growing, and can involve the orbit. I have to emphasize that orbital lymphomas without involvement of the paranasal sinuses around is not a reason to give prophylactic intrathecal chemotherapy, as opposed to sinus involvement. And the implications for having diffuse large B-cell lymphoma in the orbit, which was going to be radically treated with multi-agent chemotherapy without actually needing a surgery, or marginal zone lymphoma, which can be treated with radiotherapy a priori after establishing the diagnosis. Sometimes they can even respond to antibiotics even without giving radiotherapy, because some of these are antigen driven and infectious disorder driven. A very important point to emphasize here: please do not give steroids when somebody presents with proptosis. Some of these will respond, which will make your job extremely difficult when you want to biopsy that later on. If these are fungal infections, you can kill the patient. If these are sarcoids, they'll improve, and then you'll basically bury the evidence, and they can present in a much more dramatic form later on. The minutest doses of steroids can really hamper your ability to interpret the pathology, particularly if you're entertaining inflammatory disorders or lymphoma, and you're going to resort for a small biopsy that's going to be masked by even a few days of steroids. Please do not give steroids before you know what's going on with these patients.
I say that the current practice that if you have a patient in the ER screaming of pain, you give him steroids for no good reason. Disc prolapse, steroids. Brain tumors, steroids. Lymphoma, steroids. It's wrong. You have to be sure with diagnosis before. What are the manifestations of orbital tumor? Obvious, you'll have protrusion, because it's 100%. Because if you have a tumor which is just 1 centimeter or above, it will cause proptosis, because the orbit is very small. And if we press on the veins, it will add. And of course, the limitation of movements, in addition to several others.
Rather than proptosis alone, we say dystopia.
And dystopia.
Just actually change of the eyeball position.
True.
It could be even certain cases in ophthalmos.
True. This is Dr. Muhammad Salim, the orbital surgeon. So if you want to see the proptosis, you have to look from above. Like thyroid, you don't examine from the front, you have to go from behind and examine the thyroid. To see the proptosis, you have to look from above. Obviously, this eye is a proptosis. Here, this is so evident. You don't need anything. When you examine each eye movement alone. Right eye movements alone, left eye movement alone, and then you have to do the conjugate eye movements. Conjugate eye movements, this kind of conjugate eye movements is transmitted by the medial longitudinal fasciculus of the brainstem, and then you do 2 other movements, the so-called saccadic movement and the intermittent kind of movements, which is as if you are watching a ping ball, you are looking this way, or throwing a fly, and you see the movements. They are transmitted by the frontal lobe, the eye area of the frontal lobe. So you can see the proptosis, you can see the eye movements, like this. Here, it is obvious, but if it was subtle, you will not see it. The only way to see it is from above. And there is so-called proptosis index. You put a line from the back of the globe. Here, the line is not right, because this is going in the front. What about radiology of these tumors? You can do CT, MRI, ultrasound, PET scan, and fusion of PET with CT or with MRI or SPECT. Let's see. MRI, different sequelae, including diffusion, You can see the cuts in various movements here, the sagittal. And you can actually do the MRI on the long axis of the optic nerve. So this is optic nerve right, this is optic nerve left, and you can combine both. You are seeing the globe and the optic nerve. This is beautiful because it shows you the whole length of the nerve. Cavernomas, for example, if you give contrast, early they will contrast very well and then they will fade again. Lacrimal gland, pleomorphic adenoma, it appears in T2, T1 and in ADC, and with contrast this is histology. Again, lacrimal gland tumor. Whenever you see these are not mine. This is Ann Osborne. Ductal carcinoma. So various appearances of the bottom line is this. With MRI, you can differentiate slightly between these tumors. Sometimes you need a biopsy. Optic nerve glioma, the tram sign, as we said. Lymphoma, you need fat suppression. It looks like a tumor. It is a tumor. It looks like a tumor. It is a tumor. Fibrous dysplasia, how it looks. And the isotope. They can take, some of the lesions can take isotope. This was the histocytosis X actually. Metastases, you can see them, but you can also use the PET scan and fuse it with the CT and you can see the uptake. Melanoma, again you can use the PET scan. Orbital rhabdomyosarcoma, you can see the uptake. Lymphoma, you can also see the uptake. Usually they involve this part. They love the lacrimal gland. Lymphoma non-Hodgkin, the intraorbital pseudotumor, it looks like a tumor. And you can use the 3D CT scan. This is normally the structures that you see in normal scan, and this is the changes that you see in the lacrimal kind of lesions, lacrimal duct here, lacrimal sac. This is a sinonasal neuroendocrine carcinoma, and this is how it looks in the 3D CT, and here also the same. So 3D CT can be helpful. Angiogram is very helpful. Here I'm looking at the ophthalmic artery, which is my concern. In the, as we said, there are 7 arteries in the orbit, 7 nerves, 7 veins, 7 bones. And look at this beautiful picture of this lady that I described earlier on. This is a cavernoma in the apex, most difficult place. If you look here at the normal area, this is the ophthalmic artery. It goes from here, it crosses over the optic nerve, this is the optic nerve, it crosses this way to the lateral side, and then it jumps back again to the medial side to be divided into posterior and anterior ethmoidal arteries. This is the normal course of the artery. Look at here, we don't see it because the artery is buried inside this lesion. So my worry when I operate on this lady, a young lady of 30, is blindness. If I touch that artery, she will be blind forever. Here you can see the artery jumping from medial to lateral, and then it will go back again here. So angiogram is beautiful and it is needed. You can see here the tumor blush and the drainage into the cavernous sinus. Very important. What are the treatment? What are the lines of treatment of these orbital lesions? Needle aspiration. We have radiologists here today, yes? How often do you do, or you are asked to do, fine needle aspiration for orbital tumor? Very rare. Though the literature says that fine needle aspiration is an important diagnostic examination that should be performed whenever no contraindication. Now there are multiple contraindications. Meningioma, vascular. Cavernoma is vascular. Most of the orbital tumors are vascular, so there are sometimes contraindications to do so. It needs the cooperation of the ophthalmologist, of the oculoplastic, of the neurosurgeon, maxillofacial surgeon, the oncologist, and it's a teamwork. It's not a single person doing miracles. It's no more in surgery that one person is doing everything. We need each other. We need the knowledge of each other. We need to discuss with each other. Mainly two types of surgery, either lateral orbitotomy, if you are dealing with something lateral to the optic. If it is medial to the optic, you may do superior orbitotomy. Of course, there are other ways of doing this. This is a friend of mine, Joseph Maron. He's an Arab. He's from Lebanon, Christian Lebanon. He's a close friend of mine. He's one of the leaders in the world in orbital surgery. Another leader in the orbital surgery is one from Iraq, who's now working in the United States. So these are the multiple papers and chapters he wrote in books defining what kind of orbital surgeries are needed. I don't have to elaborate on this, but just remember the name, Joseph Maron. He's retired now, busy with his yoga classes. Transcranial approach means that we want to approach the orbit from the superior. We do this fronto-orbital. We remove the roof of the orbit, the zygoma, we cut it here, so you will end with this. Like this one, skin incision, craniotomy flap, frontal dura, temporal dura, and then you remove the roof of the orbit. The whole orbit is in front of you, like this one. This is the orbit. Or you just look at it from very superior. This is the roof of the left orbit. This is the bone. Remove the bone, you will have the periorbita. Remove the periorbita, you will get the fat, and you will get the frontal branch, frontal nerve, or V1. This is ethmoid. If you remove the fat, and you shouldn't, but this is anatomy class, then you will see the levator palpebris superioris on top of the superior rectus and the frontal nerve. That's going to divide into supratrochlear and supraorbital nerves. This is the lateral rectus, and this is the lacrimal nerve going to the lacrimal gland. Why am I showing this? Because we are going to see it in the video. So you can go medial or lateral, and you can see the optic nerve. There are so many structures in there, crowded in this very little space. This is the superior ophthalmic vein. And this is removal of structures than just seeing the optic nerve with the central retinal artery. Very nice anatomy. We use this approach in this lady, Jordanian lady living in UAE, United Arab Emirates, with this tumor. Approached it via superior orbitotomy, and we removed the tumor completely. You can use the lateral approach, that is the lateral orbitotomy, just remove the lateral wall of the orbit. And again, this is a recent article, 2015, using just the lateral orbitotomy with this small incision. So this is the lateral approach. You want to go there. This is the lateral wall of the orbit. Just there. This is pterion here. So you'll find muscles and arteries and nerves and so on. And then this is the left eye, this is the eye, this is the zygoma. You take structures here, you go in that space. Lateral orbitotomy. You can have also anterior approaches from anterior. This is left eye, nose, you go medial to the orbit like this by just mobilizing the medial canthus ligament or the lateral canthal ligament. And when you do that, you have to be aware of the lacrimal sac, the nasolacrimal duct, like this. And people can take many pathologies through the anterior approach. This is using the cryoprobe from underneath the eye. General or local anesthesia. So you can use the local anesthesia if you like. Malignant tumors of the orbit are most likely rhabdomyosarcoma and retinoblastomas. most of the time you will need excentration of the eye, removal of the eyeball, except in lymphomas. And this is one of the rhabdomyosarcoma cases. The medial wall is completely taken out, and this is a flap to cover the medial wall. Is there a role for endoscopy? Yes, but it is a limited role, usually for small biopsy. And this is some of the papers that have been published on this topic. Different approaches through the nose into the orbit. It's in the beginning, it's infancy, but it's going to be there in the future. Some people would do, again, sphenoorbital meningioma excision from the orbit. I don't need to dwell on that. What about radiation? Yes, we need radiation in these tumors. Either it is external beam, intensity modulated brachytherapy, proton beam, or gamma knife. When to give this radiation? There is some debate. Immediately after surgery or wait? Some people say don't rush, give them some time. Some people say no, go immediately for radiotherapy. I go for immediate radiotherapy if it is malignant. The advantage of proton beam over photon beam is the same. Here there is drop of the dose as we go in deep structures. So proton beam is safer than any other kind of radiation, especially if you are dealing with the orbital lesions. So low risk for ocular visual toxicity. Last time we discussed this, not because we don't have proton beam that we are okay. If patients need proton beam, they should be sent abroad for treatment. We are sending people for dental treatment abroad, so why don't we send people for having proton beam? The man and his wife and the children will go for dental treatment on the expense of the government.
I think
But we don't send.
in Egypt they will bring proton therapy.
Yeah, hopefully. Gamma knife is absolutely useless. The eye is moving, so you cannot do gamma knife. So they produce something. They want to use the gamma knife. So they fix the eye with sutures and they give gamma knife. And when they do, they give multi-sessions. Multi-session, each session costs something like $15,000. So for one single gamma treatment, you will pay $60,000, and the lesion is the same. Chemotherapy is very useful, and these are mainly the chemotherapeutic agents that are used. One question that we used to be asked in the fellowship examination in England is details about chemotherapy and details about radiotherapy. And I know that our residents don't know nothing about chemotherapy and radiotherapy. Refer for radiotherapy, refer for chemotherapy without any knowledge of what is chemotherapy and what is radiotherapy. I may go back to this. One of the complications of chemotherapy is peripheral neuritis, femoral neuritis, ulnar neuritis. If you don't know this, then your patient will come to you and you are at loss because you don't know anything about chemotherapy. So rhabdomyosarcoma are rather lethal and malignant tumors. It could be intra or extraconal, and it depends on the tumor node's metastasis classification, surgery, radiation, and chemotherapy. There are 3 types of rhabdomyosarcoma. Our case, and I'll go through this very quickly because we have finished everything. This is a 42-year-old male patient. This is a very recent admission, 1st of December, a month ago, less than a month ago. He had headaches and proptosis. How many of you have headaches? All of you. And when you ask the patient, do you have headache? دكتور, I have عندي صداع. بس صداع زي اللي بيجي لكل الناس. باخذ له حبتين بنادول وبروح. Nonsense. There's nothing called صداع زي كل الناس. Headache means headache. It has a reason, it has a cause. Investigate. And this is our man. Some proptosis of his left eye. Vital signs were normal. He was really worried and very anxious person, extremely petrified. He's young, he's rather newly married, so he did not want to lose his job, his wife, his family, and he has a reason. No cerebellar signs, no upper or lower limb weaknesses, and the blood profile is within normal. Images, that's the lesion. This is the cone, medial rectus. This is the lateral rectus. We are inside the cone, so we are intraconal. We are not outside the muscles, extraconal, inside. And look at the optic nerve, completely displaced. Look at this. And we knew from the angiogram that the central retinal artery is adherent to it and it is giving some blood supply to it. The rest of the pictures, again, medial, lateral rectus, superior rectus, levator, oblique, inferior. This is optic nerve being pushed medially, and this is the mass. So the best way to approach it is to go between superior rectus and the lateral rectus. If I can go here, I'll find it. I have to have this picture in my mind when operating. No navigation would be useful if you don't know your anatomy. And this is the lateral view. Look at here. Kinking of the optic nerve, pushing it down. And medially. The angiogram, and this is the central retinal artery. And here also. The consultations that we did, Dr. Farid is not here, he's in Palestine and doing some jobs there, but he did the angiography and he found a small feeding branch of the tumor. He did, of course, once you do angiogram you do 6 vessels. بتوقف زي تبعون السير، بتوقف الشخص عشان مخالف، تطلعش بس على الرخصة تبعته رخصة السيارة. You check on the lights, you check on tires, you check on everything. So if you do angiogram, do 6 vessel angiogram. 2 carotids external, 2 carotids internal, and 2 vertebrals, not 1. You say 1 vertebral will give me the picture of the basilar. You have to cannulate both vertebrals and have it in arterial phase, capillary phase, and venous phase. So no matter what the angiogram is, you have to get it. Ophthalmology, Dr. Ibrahim.
Good morning. So I was asked, my role in this patient is to see whether there is any effect of the tumor on the visual system, motor or sensory, and obviously there was nothing except for mild left proptosis. And by history, the patient was telling me that this was going for a long time, 2 years or 1 year, I don't know.
2 months.
2 months. 2 months, the headache and the symptoms, but he was feeling that there is some proptosis or change in his eye for more than 2 months. So I want you to tell me why did we do the surgery? Because probably
Left eye proptosis.
there is nothing here. I'm looking for my consult. So yeah, probably this is for follow-up. That's what I was thinking. So I want Dr. Ibrahim to tell us why did he perform the surgery.
Because he has proptosis, because the tumor is more than 1 centimeter in size, so you don't wait. It's the golden opportunity to operate. And he has got headache and he has got proptosis, seen by everybody at company, at work, in the street, and everything.
I have seen the patient, and actually
Yes.
you have sent me the patient, and I looked at him, and he said, yes, I have this problem
Sure.
for the last few months, and he was not, since he knew there is something in his
He
orbit, he couldn't sleep even.
Absolutely. He was so
And
worried.
this has to come out. Anyway.
Absolutely, agree. This surgery, because of the insurance reasons, were done at another hospital. There was no insurance for him here, and it was done at Gardens Hospital. Dr. Abbas Al-Tawil was there as an anesthetist. I will take this opportunity to welcome Dr. Muawiyah Ababne. Is coming with us today. Muawiyah was the chief anesthetist at Jordan Hospital. He has retired from there, kind of thing. So, would you like to make comments?
Assalamu alaikum. Thank you very much, Ibrahim. Number one, on the team, the whole team, included by my beloved Ibrahim. This is not first time. He put all the people involved.
That's for diagnosis.
And care of patients, but anesthesiologists were not included. Before 2000, we were taught that most powerful stimulus to the body was surgical incision. After 2000, things has changed. And the new books, they taught that the most powerful stimulus to the mankind is endotracheal intubation. So I think anesthesia should play a major role in success of the patient and the outcome, especially these tumors when they are vascular, because the type of induction of anesthesia, type of maintenance, type of extubation. And after year 2000 as well, we thought that I'm sure you know about fast track anesthesia and enhanced recovery anesthesia. And this is applied in even cardiac surgery nowadays, even neurosurgery. We remember when we were together in Jordan University Hospital before year of 2000, we used to anesthetize patient, intubate them, leave them on ventilator for probably 2 to 3 days. Nowadays, I mean, we've got major super clean drugs and anesthesia, eliminated with no metabolism in the body. They don't need any plasma sterases or anything to get out of the body. Same with inhalation anesthetic. The new inhalation anesthetics even cleaner than the air we breathe. The last one, desflurane, metabolized 0.002%, which is a sample from the air. It's about 0.2% with argon and contamination from the atmosphere. So nowadays, I think anesthesia plays, as I said, major role in success. Intubation with these patients, in neurosurgery patients mainly, and all patients, but it could be disastrous right at the beginning, especially if there is increased intracranial pressure, especially if it is vascular, and you might need to worsening of the prognosis or the diagnosis of the patient and the outcome. I think today probably I can claim anesthesia today probably at its peak, at its best, from point of view of drugs and inhalations and the outcome of the patient. We managed to do the operation with Dr. Ibrahim 10, 12 hours. As I said, fast track, smooth recovery, and he insists all the time on neurological examination and assessment immediately post-operative, where a few years back we couldn't do that even 3 days later. Thank you.
I've known this man and Maawi Ababni for the last 30 years. We work together for different hospitals, different units. In addition to being a top-notch anesthetist, he is a top-notch pain management specialist. So if you have any problem with the pain management of cancers with post-laminectomy, he's your man. The consent form, the detailed consent form, not the usual consent form of hospitals, including Farah. It is a general consent form. It does not work, believe you me. And what we will do is the lateral orbitotomy. You will see the lacrimal gland will go on top of the lateral rectus, because that's what we said, between the severe rectus and the lateral rectus. This is anatomy, cadaveric specimen, but it shows you what we are going to do during surgery. And we will have some attention to the severe ophthalmic vein. Okay, let's see the surgery. Okay. Left eye, this is midline here, head is tilted. We have removed the roof of the orbit, part of the roof of the orbit and the lateral wall. I'm continuing the drilling here to make sure that I see well. This is the roof of the orbit, part of the roof of the orbit left. And what appears here is the dura of the frontal lobe. Of course, the dura of the temporal lobe is here. This is the lacrimal gland. It's sitting in my way, so I would like to put a retractor on it and retract it. So I do. I put the retractor and take it anteriorly this way, so that I will have the lateral wall of the orbit. I want to go there. I know I want to go there, and I make sure that this is right by doing the navigation. If the navigation says something else, I ignore the navigation. And many a time the navigation will break down. So you have to depend on yourself. This is the superior rectus and the levator of the palpebrae superioris. I want to take them this way, so that the rectus is here. I want to go in this area. And the fat, the periorbital fat, is the most troublesome of everything. It's there in front of you, it does not retract, it's cumbersome. But you know your anatomy, this is the superior oblique and levator. And this is the fat. Here we can see the superior ophthalmic vein. It appears now. These are the muscles. Superior orbital vein. I take it this way. And then I start to see the bluish color of the tumor. You can see the fat is hampering your way. This is the mass. Again, make sure, I know it is the mass, I know I am right, but let's confirm it. For the sake of our body, I opened it, it's vascular, as we expect. No drop of blood is allowed in the orbital surgery, and the brain surgery for that matter. I use the ultrasonic aspirator to evacuate it from within so that it will collapse, and then I'll go around it. If there is any blood vessel, I coagulate it and then remove it in one piece. It is not necessary that you remove it in one piece. We don't make a rule of this. This is the last blood supply here, which is a branch from the central retinal artery. So that is the mass. And then this is the lacrimal gland being put into place, complete hemostasis.
How long was the operating time?
About 4 hours, 4.5 hours. So,
Can I comment now?
yes, please, of course.
It has long been a friendship and a colleague, Dr. Ibrahim. We worked together for some time. Actually, I do remember in the early 19s, when I started orbital surgery, I had a lecture arranged by the Ophthalmological Society for me in the 1994 about orbital surgery. And I had a collection at that time, and he was there. He came, and I admired it. Maybe the first time I could see him at that time, where he told us something about the orbital surgery, is that it's a neurosurgery approach that we are, as ophthalmologists, came into that. And since then, it was my not only concern, but it is now a hobby that I do orbital surgery as ophthalmologist. Why we now? We are about maybe more than 10 oculoplastic surgeons who are doing ophthalmologist. I know that you are tired now that Dr. Ibrahim has been bombarding you with a lot of knowledge about orbit, and that was very great. But why is that, especially when I see intraconal lesion, there is a difference between an orbital lesion that came from the cranial cavity, or where the brain is affected, and whether it is a primary orbital lesion, like the one like intraconal. Now, intraconal masses should be dealt by ophthalmologists, simply because the main complication of it is diplopia, ptosis, or sometimes, as you said, lacrimal gland or lacrimal system, and these can be dealt by ophthalmologists. Now, these cases I do in 1 hour time, whether it is lateral orbitotomy, it takes a longer time, or some of these cases I have done transconjunctival. Transconjunctival, that means as if I am doing squint surgery, or as if I am doing retinal surgery. I ligate the muscles, I cut the muscles, I go into that يعني I retract the globe and I turn the globe into the counter side, and then I go to the optic nerve as if I am doing optic nerve fenestration, or I am going to do a knee at tumor. I have done this, and I have put that in my page in the Facebook. And if now the knowledge and the expertise in surgery is going smart and easier, I mean, like if we don't have to, an orbital surgeon, ophthalmologist who has been trained on orbital surgery, he does the job of the oculoplastic, the job of the ophthalmologist, the job of the neurosurgeon or whatever. And he can deal with the complication to the end, because it is either double vision, he want to deal the squint, or ptosis, he want to deal with it, or lacrimal gland or lacrimal system and so forth. And it's also time consuming, I mean, and it's a cost effective. This is we have to confess that. For example, I want to share with you also, for example, we are, as oculoplastic surgeons, we see the worst ever blepharoplasty done by a general plastic surgeon. Okay, because we are doing it much better. And for orbital surgery, I think we could do in a much shorter time, and we can deal with the complication to the end, with all my due respect to you.
You can do it in shorter time, but we do it in a better way.
I don't think so.
Yes, please.
صباح الخير، أنا سامر خرمة, orbital surgeon, 20 years in the Royal Medical Service. Thank you, Dr. Ibrahim, for this beautiful talk and illustrated. طبعا نتعلم منك forever, we'll keep learning from you. But really, Dr. Ibrahim, I think what Dr. Mahmoud said is really valid. Now we do it through a lateral orbitotomy, skin crease, hidden incision, 1 hour, 1.5 hours. And I'm sorry, Dr. Ibrahim, full friendly atmosphere. There is very vital thing during our orbital surgery, which we do, which maybe it's difficult in your approach, in neurosurgical approach, is that we keep monitoring the pupil throughout our surgery. We stop traction once we see the pupil playing. This is something maybe you will not be able to do.
No,
this.
we can. Of course.
Okay, that would be lovely, Larry. Thank you. Thank you, Dr.
سوري للتأخير بدو تأخرت بس خلينا نخلص عشان في ناس مستعجلين. This is tumor. This is the gross picture of the tumor. You can see هذا black lobulated part tumor حوالي 2 سنتيمتر. This is the tumor. You can see very much dilated the blood vessels with abnormal walls, and you can see some of the blood vessels reaching up to the end. يعني imagine if this one of them ruptured, how the patient will have, how much problem he will have, and that's why I think surgery was indicated. There was no nerve. You can see that this is the periphery of the tumor, but very much dilated blood vessels, and these all are communicating channels. All of these are connecting with each other. It's not one channel separated. You can see again here, and this fat tissue up around the orbit, but there was no nerve tissue or brain tissue attached. Again, you can see how these are very much dilated and communicating, and all these are, you can see them, they are communicating with each other, separated by fibrous tissue. And here you can see some of them are have fibrin in them and thrombi and recanalization, starting recanalization. And this is typical of this tumor. We did several immunostaining. CD31 typically stains the endothelial cells, and you can highlight the margins of the tumor. And this is CD34, another endothelial cell marker. All of them, they have different indications, and you can see the highlight of the markers. Factor 8 is negative in this case. It's another third marker, but it was negative for endothelial cells, and it was negative. See, S100 shows some nerve fibers, twigs of nerve fibers in between the cavernoma, but no large nerve fibers. But S100 also stains fat. This is important. It stains nerves and stains fat, and this is the fat tissue that's positive. P53 was negative in this case, and Ki67 was negative in this case. So this was a cavernoma or cavernous tumor.
I think we have a common interest in حساب ابو فرسخ.
Of course.
قديش عدد الحالات الاوربيتال اللي بعت لك اياها بالسنه؟
ممتاز.
We are not in a competition, Mahmoud, here. What I started with is to say that this is an area that needs cooperation. In that surgery of mine, facial-maxillary surgeon was there, let me finish. And there was an ophthalmologist, oculoplastic there, so we need each other. But to say that you can do it from A to Z alone, this is totally wrong. You are defeating the teamwork system of medicine and surgery. And I tell you something, I have seen disasters coming from the so-called oculoplastic surgeons. Yes, of course. Of course. Thank you, that's what I'm saying. This was a posterior intraconal.
It was anterior. It was anterior.
So that was the diagnosis. And these are the post-operative images. Total excision, as you can see. No remnant of the tumor and good reconstruction of the lateral orbitotomy. This is to show you where the cut of the bone was. Again. Muscle is there, bone is there. So this is a proof that all was well after surgery. No complications, nothing. Of course, usually they have edema of the eye, which can be dealt with easily. And this is the follow-up of the patient. And this is the discharge summary, which is made of 15 pages. Not single flimsy paper with nothing on it. That says everything about the patient. So that was orbital lesions. In summary, with this particular case that has been presented, the floor is open for discussion.
Question. What's the natural history of this without intervention?
Natural history of cavernous hemangioma is to continue growing. There has been no report of cavernous hemangiomas sitting still. Usually they just go on growing. And in the orbit, anything more than 1 centimeter is going to cause you a problem.
Absolutely. If I may comment here, now this is one setup where you cannot do a CT scan guided biopsy. FNA, for the sake of residents in the room, there's a difference between FNA, and I don't want to step in those of interventional radiologists here, and true cut biopsies. FNA and most of the lesions we've seen in the differential diagnosis is going to be a waste of time, because what you're going to do is to see a smear for cytology. If you cannot get a bigger biopsy, a bigger specimen, then it's a true cut biopsy, which is a wider core, and it's still limited because you're seeing a small core of tissue that you opening for differential diagnosis. And given how wide the differential diagnosis is, sometimes that's really problematic, particularly if the patient has received steroids before that.
Question?
And,
somebody else.
يعطيك العافيه. حكيم دكتور قاسم مصر اوكيوبلاستكس. دائما في ديبيت بالايس اوبرز بالامريكان سوسايتي اوف اوبتالميك بلاستيك سيرجري كونفرنسز. كافيرنس انا اشتغلت بام دي اندرسون بهيوستن. Cavernous hemangiomas in particular, يعني the working diagnosis from the imaging is cavernous hemangioma.
Most likely, yes.
With proptosis, most likely, or more than likely, the cavernous hemangioma has been there for more than a couple of months. يعني even يعني مرات تسأل المريض بيقول لك أنا هلا لاحظتها بس طلع على صورة هوية يكون عنده proptosis probably a couple of years ago.
True.
فبهيك حالات especially إنه الدكتور إبراهيم شافه كان الفيجن 6/6 no visual field defect, no optic neuropathy. And I completely understand the patient is anxious. بس God forbid صار عندك optic nerve injury أو أي شيء طلع البيشنت عنده no light perception post-op أو diplopia. يعني what I'm saying working diagnosis من ناحية surgical intervention bearing in mind اللي حكيته أنت هلا إنه it will continue to grow. Have you seen it always continue to grow؟ لأنه من مرات كتير من هاي الحالات we do continue to observe. I have personally myself seen a few cases that I've continued to observe. وما كان عندهم any symptomatic optic neuropathy أو أي شيء for that reason. لأنه surgical يعني in my opinion the risks outweigh the benefits. إذا البيشنت عم بيجيك 6/6 ما عنده diplopia
You want to wait.
very mild asymmetric يعني proptosis مش شيء cosmetically that warrants intervention. But I'm just asking you from your experience, do you always operate على cavernous hemangiomas, or do you sometimes observe in a case which is otherwise asymptomatic?
If it is less than 1 centimeter, I wait.
For any 1 centimeter and above is your clinical indication to operate?
Yes. Especially that, as I say, our role now as doctors is not to choose the way of treatment. Our role is to tell the patient what are the options he has. We say, you can wait on this and let's observe it so long that your symptomatology is low, or we can operate. And the patient has to choose. This patient went straight forward for surgery. He was so worried, he couldn't sleep. He just, his life was miserable from the cosmetic point of view, from the headache. And when he saw the pictures that it is pressing and pushing the optic nerve, he was just adamant that we will go for surgery. So I take your point. In many neurosurgical cases, I wait if the symptoms are very mild and if the natural course of history is very prolonged. The cases that I've seen, all of them grew, but in a different period of time. They are slowly growing. Sir Ibrahim.
At the end of my presentation, Dr. Ibrahim, I saw the patient probably few weeks before he was operated.
3 weeks.
Few weeks. And at that time الأمور كانت تمام ما فيش أي مشاكل. بس خلال 3 weeks بجوز 10 دكاترة حكوا معي neurosurgeons and ophthalmologists that you saw this patient شو رأيك؟ فهذا المريض كان he is very worried. فبروبلي هذا شكل ضغط على الدكتور إبراهيم لأنه هذا المريض ممكن يوقع. بالضبط بجوز لما شفته كان بالضبط يعني بجوز معظمنا بالقاعة شفنا.
أنا أقول I operate on them as soon as I see them. The space occupying lesion in the orbit. As يعني هذا حجمه يعني حجم الآيبول.
I personally add an indication which is called the patient factor. Anxious patient. If the patient is anxious والحالة controversial, I do it لأنه إذا راح على واحد mediocre ممكن يخرب له عيش.
هذا بالطريقة اللي أنا بسويها transconjunctival ونو ستيتش يعني أنا ما بعمله زي أكثر من عملية حول. عارف كيف؟ بس بربط العضلات بقلب العين بالكرايو بتطلع. يعني الأيام تغيرت عارف كيف الأيام. طبعا we are doing it.
No, you are implying that we are doing the old tradition. We are doing the current tradition. Orbital surgery has been traditionally a neurosurgical field, and the oncologist, the ophthalmologist came in. It's just like spine surgery, it's traditionally neurosurgical, and some spine and general surgery came in. I accept that it is a teamwork, it is not a single person work. Okay, we'll finish with this, and next week, next Wednesday, we'll talk about brain stem lesions.